Good evening, everyone. Thank you for joining us for the first session of our START assessment series today, organized by the British Sudanese Association of the Pediatric and Child Health. This series is designed to help us as the trainees prepare effectively for the START assessment, which is a crucial milestone in our journey toward becoming a consultant. Just try to move my slide. Our aim of this series, the idea of this series came from the recognition that preparing for START can feel challenging, but with the right guidance and resource, it can become an empowering experience. Our aim is to provide a structured program led by experienced consultants who have recently completed the START assessment, and they will share their insight and practical advice to help us navigate this process with the confidence. Our target, it is the level 2 trainee from ST6 to ST8. And we have planned this session to be confident and consistent. It will take place as twice per month on Saturday at 7 p.m. This timing helps us to participate without conflicting with the clinical responsibility. Each session will be 45 minutes long and 15 minutes for the question and answer focusing on one or two key areas. Our aim to cover over the next 4 months, we will cover a range of topics, including critical appraisal, safe prescribing, teaching, tips about the handover, conflict management, also about the ethics, business case, safeguarding, leadership and team working, and the case-based discussion. Each session will be designed to focus on specific challenging and skills required for the assessment. I would like to thank British Sudanese Association of the Pediatric and Child Health, and along with the academic and media office for supporting this initiative, and the consultant who are generously offer their time to share their experience with us. Feel free to email me or send me any WhatsApp group for any question about the START series. If you would like to share question for upcoming speaker, I'm happy to help and ensure your concerns are addressed. Today, the first session will be today, and will be cover introduction about the general tips about the START series. It is my pleasure to introduce our first speaker, Dr. Nadia Baasher, who will set the stage for this series with an introduction to the START assessment and general tips on how to approach it. Dr. Nadia Baasher is a pediatric emergency medicine consultant based in London. Her experience and insight will provide us with a strong foundation as we get on this journey. Please join me in welcoming Dr. Nadia Baasher. I will stop sharing now. And I will give you the microphone, Nadia.
Thank you, Ayat. Thank you for inviting me to do this talk. Good evening, everyone. My name is Nadia. I'm one of the PEM consultants working in London. I'm going to talk to you today a little bit about a general overview about START and a sort of template to answer your questions and what to expect in the START assessment. I'll just share my screen. Can everyone see my slides?
Yes.
Okay. Are they moving?
Yes, it's moving.
So the objectives today is to give a general overview about START assessment, what to expect, stations. I'll provide you a sort of an answer template, which you'll be able to sort of use in all the stations in START, and then sort of top tips for each station. Okay, So generally START is specialist trainee of readiness for consultant, basically. So they are assessing you as a day one consultant. They're not assessing you as an experienced consultant. They're assessing you as a senior trainee / your first day as a consultant, what you would do and how you would navigate. And what I want to say is this is something you as higher trainees, you do every day. You navigate these logistical issues every day. The clinical perspective is absolutely fine. This is your day-to-day bread and butter. However, when you're in a situation where you're being assessed, they like to say it's not an exam, but the reality it's an assessment. You're being assessed. You need to sort of prepare in order to have a sort of a really rounded up, nice answer ready. If you had an hour to sit and talk about this, you'd be absolutely fine. You wouldn't need to prepare for it. But I think that the prep element is just sort of perfecting your answers and getting them rounded up so that you don't have much remediation to do afterwards. People have often asked how much preparation do I need? How many weeks? Like people have said they've started 20 weeks, and it's not like that. It's not like the exams, like the clinical exams or whatever exam you're doing. It just needs a little bit of practice with a group. That's the most thing that I found very effective, with a group of people who are doing the exam. Maybe just 2 weeks before the assessment, maybe just 2 weeks before, a couple of evenings, and it's absolutely fine. There may be some documents you need to just refresh yourself, and that's it. It's not a big deal. Everyone who has done START will tell you it's not a big deal, but if you are doing it, you're in the situation of, oh, I really need to practice, I really need to prepare. So it's 10 stations. You have a critical appraisal station, you have a safe prescribing, safeguarding, teaching, clinical, which is 3 scenarios, so that makes it into 10. You have a handover, you have ethics and conflict, or sort of a logistical, navigating sort of logistics within the workplace. So those are your stations. The scoring, what the elements they're scoring you on your decision making and prioritization, managing complexity. So these are all things that you would be thinking of as a higher trainee or as a consultant. Managing safety and risk, your knowledge, your communication, and sort of, I can't see this, professional approach in general as a consultant, day one. So then at the end, there's an overall score. So these are all the elements that they're scoring, and then there's an overall score at the end. The scoring system, either you score above expectations, which is usually there's nothing you need to do. Meet expectations, also likely nothing needs to be done. If you have a station where they scored you as you need further development is required, then they will give you suggestions of things that they need you to remediate on, which you will need to do before your final ARCP, or actually prior to when you're applying for sort of your CCT. And then if there's a station where you've got significant concerns, I believe this is quite rare, like for somebody who has reached the level of ST 7, 8 or whatever to encounter this, unless there's a major issue on the day. So this is the scoring system. Above expectation and meet expectations, likely you need to do nothing. It's the further development, they will give you suggestions to do. This is sort of an answer template of all the sort of, if you take a picture of this, then you'll be able to apply it to every question you get. And if we have time at the end, maybe we could practice 1 or 2 questions if anyone is up for it. So the first thing in your answer is patient safety. Well, there's a clinical scenario, a governance scenario where a mistake has happened, a conflict with a colleague, safeguarding, obviously. So always the prime element is patient safety. This is what you want to maintain. Now you're in a situation, the first thing I need to maintain is, is the patient safe, and is the department safe, for example. Then you need to have a holistic overview. A lot of the scenarios are not just about your clinical knowledge, but it's more about your, as a pediatrician, a holistic overview of the child, the complexities, the social elements, the rest of the household, the safeguarding elements. So you have to take a holistic approach in general. A lot of the scenarios will be sort of multi-layered, where there will be lots of sort of aspects, so you need to think about those in general. Then every scenario there will be an element of governance and risk management, so that's one part. And then thinking about colleagues and thinking about the team. If there was a situation where a colleague was a difficult clinical situation, then you think about things like debrief. If there was a situation where a colleague is being obstructive, you need to think about the rest of the team. If there was a situation where the parent was being difficult, you need to think about that individual where the person was difficult to and the impact on the rest of the team. Gaps in the rota, how this is impacting the workload and the colleagues. So you have to think as the most senior person, the person that is in charge, generally the person who has to keep it together. Basically, that's the mindset you have to go into the exam with. Yes, you haven't done it before. Yes, you've done it on a clinical perspective, maybe not as much as a management, but you often do it on your night shifts when there's no consultant around. But you think of yourself as consultant day one. I have to keep the whole show together. Then always when there's always, if there's a difficult clinical situation or complex clinical situation or a safeguarding situation or governance or conflict or whatever, there's always scope for future improvement. So what can we do for this not to happen again? Or what have we learned from this and how can we improve in the future? Or what changes should we make? And then to make your answer nice and rounded, there's always a learning opportunity from everything and a teaching opportunity. So it's opportunity for you to teach, for your juniors to teach, for a session to happen. So if you look at all those elements, you will be able to bring them into every aspect of your answer, and that will give you a complete answer. You will tick all the boxes. If I go back a few slides, look what they're scoring: decision making and prioritization. That involves safety, it involves clinical decision making, it involves logistical decision making, it involves those three: managing complexity, a complex clinical case, a complex social situation, a complex safeguarding situation, a complex situation on the ground in terms of logistics. So again, they're assessing you. These will come back. If you put those two slides together, you'll be able to match how you're being scored. And if you use that template, you'll tick all the boxes. And it's about ticking boxes in reality. As I said earlier, if you have an hour to sit and chat about these, each station, if you're sitting at your ease and had an hour to say it, you will discuss all the elements. However, in a situation where you have 20 minutes or whatever, forgive me, I forget the timings, I can't remember, but I'll try to. When you have 20 minutes to do this, you need to have some element of some template in your head or flow chart that you're following, and some element of practice, just for purposes of assessment, not because you don't already know all this stuff. So I'll go through each station one by one and give you sort of tips for each station and how to navigate and what the main points are for each one. So the critical appraisal, you'll get the article five working days before your assessment. It's usually something that's relevant to your subspecialty. You can use the CASP formula or the appraisal scheme. You can use that depending on the article. If it's there's multiple options based on what the article you're given. So basically what I did is I went through the article and I appraised it using the CASP model. And then you're allowed to take your paper. I printed out the CASP and you're allowed to take it with you to the exam for the discussion. Okay, they'll send you a paper, and with the paper there'll be a scenario. So the scenario will be sort of relevant to the paper. So just remember to link your appraisal to the scenario that you're given. So for us, it was a paper about inappropriate prescription of antibiotics, and the scenario was looking at was a patient who had been seen in the urgent treatment center, had been prescribed antibiotics for an upper respiratory tract infection, and then came back 3 days later still having fevers, was seen by the AMP. The AMP felt that it was viral and there was no need for the antibiotics to be commenced. So the AMP is come to discuss with you based on this paper that we need to discontinue the antibiotics. So you have a sort of evidence-based discussion, and based on this paper, are you going to discontinue the antibiotics, or are you going to complete the course? So just remember to bring it back to the scenario. What they are assessing, they're assessing two elements in the critical appraisal. The first one is, can you critically appraise a paper? And I guess all of you can. We've done this multiple times in journal clubs, and you do it day to day. And can you apply this knowledge in your settings? So the first part will be appraising it and ensuring that you understood the article and you're able to appraise it appropriately. And the other part of it will be, is this applicable to your settings or not? And how would you apply it in your settings if you wanted to go about applying this change or this based on this evidence? Just remember to bring it back to the scenario. I forgot, I sort of appraised the article and had a big, long discussion about the article and about whether it's applicable to my setting or not. And then the examiner sort of had to prompt me to say, okay, so what would you say to your AMP? And I had forgot completely that there was a scenario involved. So just remember to bring it back to the scenario so it looks better. Just say, so in this situation, the question posed to me by the AMP, I think it's appropriate for us to discontinue the antibiotics based on the evidence. So just remember to link it with the scenario. So it's quite straightforward. This station, it's like a given. You get the paper in advance. You can prepare for it. You can prepare your discussion. It will flow very easily. So there's not much issues with this station. Moving on, prescribing. So prescribing is a little bit tricky, not because we don't know how to prescribe, but because of the time. And I guess I don't know whether this changed or not, but is the software, the college, you sort of have to scroll right and left and up and down to see the prescription. You don't get sort of a view of the whole prescription like you would if you were holding it in your hand. Also, I'm not very tech savvy, so I think some people know how to download it to the computer and open it. I was sort of like going right and going left and going. So that is a bit distracting when you're trying to do it. You do have ample time to look at this prescription. Like, I think I can't remember, but I think at least about 20 minutes, if I'm not mistaken. We can check the actual timings and next time update you. But you do have good time. So what I suggest is you have a piece of paper and a pen and look through the prescription one by one. So there's a few elements with prescribing. So it's about the prescription itself, and it's about then managing what went wrong with that prescription. So it's a prescription error commonly, and then there will be a scenario. So-and-so prescribed the double dose of whatever, then what happens? So again, two elements. So the first element is looking at the prescription itself. So this is not the one from the exam. This is something I put together, but it will look like this. Make sure you scroll through every part. So just get your piece of paper and look. So the name, just make sure it's written in block capitals. The spelling is correct. It's well, you wouldn't know. There's no abbreviations. It's a full name in block capitals. Date of birth is correct. The hospital number, the allergies are ticked. The weight is there. The unit of the weight is there. The drug, it's written correctly. The start date, the stop date, the signature of the person prescribing, and their sort of GMC number or whatever. And then once you've sort of looked at all the sort of housekeeping of that, as it for want of a better word, as it may, then you look at the actual prescription and where the errors are. So the dosing, if you want, they will allow you to have the BNFC if you need it. Usually it's something very basic that you don't really need. They're not going to like bring a weird and wonderful chemotherapy or something. They're basic drugs that we use all the time. And the scenario will tell you what's sort of happened. So you've established, like in this scenario, you've established that, for example, the name of the baby is bed 1. There's no name, there's no the date of birth, there's no year. The allergies haven't been filled in. There's no unit for the weight. There's no start and stop date for the Prostin or the gentamicin. There's no signature. The gentamicin seems to be a massive dose based on if it's a 3 kg baby. The Prostin is all over the place. So then that's the first element, is the actual, then what happened and how do I navigate this? Okay, so again, go back and think about my template. So first thing is what? This patient has been given these medications, for example, a massive dose of caffeine or a massive dose of gentamicin. Think about the template, patient safety. I'll go to the bedside, I'll do an ATE assessment, I'll stop the medication, assess the child, whatever, clinically. We'll take blood tests for renal, if it's gentamicin, for example, renal functions, whatever. And then duty of candor, we need to explain to the parents that this has happened. Then I would need to fill in an incident report. Then I go back and have a look where the error has happened. So the question I got was sort of multi-layered, and all the start questions are multi-layered. So it was the SHO who prescribed the wrong dose, escalated by the nurse to the, and it was given. It was escalated by the nurse to the registrar, who discontinued the dose, which was a big dose of caffeine, but continued the maintenance. So again, didn't omit completely the caffeine until we made sure the child was okay. So then, safety of the child, communication with the parents, the duty of candor, the logging the incident, directing the parents to PALS if they want to complain or whatever. Then you have to think about your team. So the nurse who's given the drugs, the person who's prescribed it, where was the error? Was it a giving error? Was it a prescription error? If it was a prescription error, why? You have to look into this. Why is this happening? Is it a one-off or is it a recurring issue? Was this person prompted that this prescription was wrong and insisted to continue, or was the person overwhelmed, was doing multiple things at the time? So looking, does this SHO need time, need to not be allowed to prescribe, needs time to do prescription courses, needs time to shadow the pharmacist? These things you need. Does it need escalation to their supervisor? Same with the registrar. Then teaching for the department for the importance of, and then does this need to go? It will go to the local governance in the unit, obviously, because it's an incident report. It will be discussed at unit level. Has harm come to the child or not? Does it need to go forward to trust level, for example, governance? Unlikely in drug errors that they go to trust level, but was the harm significant enough that it had to go to be discussed at trust level, or was it enough and it was closed and discussed in the unit governance? Then you need to think about things of how do we prevent this from happening again? Do we need to adhere to our trust protocols for prescribing? Are these easily accessible to the people prescribing? Do we need more training? So these, and then always a learning opportunity, teaching opportunity, discussing the case in the M&M. So if you go back and think about the template, you'll hit all the boxes: safety, communication, governance. What else? You're going to hit all the boxes that need. So every station, although they're very different, the same template will apply. So when you're practicing, just think of that. And then safeguarding. There's a lot of safeguarding in START. It's not just the one safeguarding, the one that's named safeguarding station. There's a lot of safeguarding within the clinical scenarios. There's a lot of safeguarding even in the prescribed, anywhere safeguarding is slipped in. And this is something that is the reality of our day-to-day practice. So like even when I did my first station, which was safeguarding, was the first one. And then I finished that, and then I went on to the clinical scenarios, and the 3 of them had a safeguarding element in them. And I kept saying to myself, is there something I'm missing? Am I getting it wrong? It can't be all safeguarding. I was doubting myself. And then when I spoke to other people after the assessment, there is a lot of safeguarding in START. So always think safeguarding, which we always do anyway. Read on documents around parental responsibility. Look at often when there is a safeguarding case. So think of yourself as a consultant day 1, and the complex safeguarding case comes in. you need to know where to access support within the trust. You can't sort of navigate these cases on your own yet. So have a chat with the named doctor for safeguarding within your trust. So these are things you need to mention in the assessment. So it's not just about, oh, I've identified this as safeguarding, I'm going to do a body map and do the safeguarding pro forma. Yeah, that's at registrar level. But then moving forward, what do I, and then they'll discuss tomorrow morning, moving forward, what do I do? So I need to have a chat with the named doctor for safeguarding. I involve the nursing for safeguarding. If I was in doubt, I'd look at the RCPCH Child Protection Companion, which is a online book. Then it always mentions, seeing that this is my start of my consultant career, and I'm junior consultant, and this is sort of quite a complex safeguarding case. I would need to sort of discuss with my peers, discuss with more senior consultants who have may navigated this before, to run it by them, and that. Then supporting junior colleagues. One of my clinical scenarios was a child who had a head injury, and there was a safeguarding aspect. The mechanism didn't make sense. And then the examiner said to me, okay, so your ST4 has called you and said they're not confident to manage safeguarding. So what do you do? So you need to come in, you need to be on the floor, you need to support them with the process and that. And then, again, always an opportunity for teaching. So if you go back, I'm going to keep saying this the whole session, just to emphasize the importance of the template, of having a template in your mind. So again, safeguarding is obviously patient safety, but then again, communication, teaching opportunities, looking at what we can do better, governance, so again, it applies when you're answering in each station. So these are the main things you need to think about in safeguarding, or mentioning the named doctor for safeguarding, the named nurse. Those of you who do community pediatrics will be more clued up on this, and they'll be able to have a more it'll be easier for them to have these discussions. However, I think all of us should be aware of sort of the basics. Teaching. So teaching is quite basic. You've all done teaching. It's nothing that I'm gonna teach you how to teach, as it were, but just a few sort of logistical things. So you'll get topics, like 3 topics, I think, to choose from. No, actually, you'll get 1 topic, and then there'll be 3 points in the topic. You'll choose one of the 3 points to discuss. So, for example, constipation, causes of constipation, managing constipation. So you don't have to discuss all of constipation. You pick 1 point, because it's only like 10-15 minutes that you have to do this. You'll have 3 medical students, or people who are like say that these are medical students. But they do, what you need to be mindful is they're not just there as actors, they do give feedback on your style of teaching. So they do feedback as part of your assessment. Try to keep it interactive. I remember one of the things that was fed back on mine, that the students appreciated that the teaching was interactive. Try to introduce yourself. I don't need to teach you to teach, but just in the heat of the moment, you might get stressed and forget to say hello, introduce yourself, ask them their names, ask them previous understanding of the topic, make it interactive. Don't forget at the end to summarize. Similar to when you've done exams before, like RCPCH or whatever, it needs to be correct information. So for my one, it was the COVID vaccine. So I took a bit about, I can't remember what point I spoke about, but don't get yourself into complex. Like if, for example, the COVID vaccine, don't say, oh, think about the molecular workup of the, don't, because if you say something that's wrong, then you're going to get scrutinized for that. So just keep it very basic, medical student level. Keep it short and simple so that you can have enough time to summarize and ensure that you've achieved the outcome. So the objectives of your teaching, go back and make sure that you've achieved the outcome with your students. Very straightforward, the teaching. They'll comment on your style of teaching, on your interaction, on the content. It's again a station that's easy to get, like, no issues. So yeah. Then the clinical scenarios, you'll have 3 scenarios based on your specialty. If you are sort of the only issue is just to be mindful on the day is when you go through the document of all the scenarios, just make sure you're reading the scenario which is your one, which is based on your specialty, whether it's neonates or general peds. Sometimes you have to scroll down through to find. I know the sort of knee-jerk reflex is just as soon as the scenario comes on your screen, you just want to read it and make sure you know it and get it done quickly because you're anxious about it. You just want to make sure you've read it, so just make sure you're reading the scenario that you're supposed to be reading, so you don't go into the room and you're discussing something very different. So just find your specialty and make sure that you're reading the right one. Again, these are sort of technical issues. Always a holistic approach. They're always sort of multi-layered scenarios. It's not just a straightforward clinical scenario. It is clinical, but there will be other aspects. There'll be social aspects. There'll be safeguarding. There'll be, for example, I'll give you an example of a clinical scenario. So you're in the A&E. You have a child who has only been 2 weeks in the country from Africa, has known to have sickle cell, and has come in with difficulty in breathing. So there's can you see the multiple layers to a scenario like this? And they've given you the observations or whatever. So this is about your now acute management, but also about this family is new to the country. How are they living here? Are they on a visa? Do they have rights to treatment in the UK? In terms of the sickle, who's looking after that? What's their history? What's their sort of baseline for the sickle? Who's been managing that? Have they had the vaccinations? Are they on prophylaxis? Then are they linked into services? Do they go to school? Have they registered with the GP? Who else is in the house? Are there other kids? Are there other kids who have sickle in the house? What kind of family support do they have here? Are there any safeguarding concerns? So multiple layers that you will need to think about. It's not just, oh, there's a sickler with a acute chest crisis, we're going to manage that. And then, yeah, for us in ED, yeah, but we're going to manage the sickle crisis. But it's always a multi-layered scenario where there's multiple aspects, whether that be trauma for those of you who are doing PEM, with a bit of safeguarding, with a bit of social complexity, whether that be, again, neonatal issues with, again, social complexity. So it's always multi-layered. Again, you can go back to the template and then learning. So my registrar who looked after the child will have a discussion about the case, and it's an interesting case, and they've looked into this. Actually, we don't have a guideline for like patients who have, for example, like if it's a patient who's completely moved from a new country, what's the guideline? What tests do they need to do? What vaccinations do they need to have? So there's multiple layers where we can look into different things, and there's always an opportunity for teaching. So if you go back to the template, you can apply it in any situation. Then think of the clinical scenarios about leadership and delegation and discussions with other teams. You're the consultant, so you have to take your mindset out of actually doing the things by yourself. So I will do this, I'll put cannula in, I'll do the bloods. No, I'll ask the reg to do, I'll ask the SHO, I'll do this. I will be on the phone, I'll be speaking to the hematologist. I'm having a discussion. I'm going to ask the nurse to look in to see if these family are known to social care. What's their situation? Do they speak English? Do they need a translator? So you have to do all the sort of logistical. So think about delegation and leadership, and supporting junior colleagues in this clinical scenarios. For example, my scenario, when it was a safeguarding and the ST4 said they're not confident to manage it, so I have to support and come in. And then there's always opportunity for learning and teaching. So if you look at the steps and you go back to the template, you're actually answering all the questions based all the points in the scenario based on the initial template. Handover. So handover, this is so that was the only station so all my stations were above or whatever, and the only station that I had some development was the handover. It was my last one. It's quite a long day, just so it's a long day sitting in front of a computer. I'm not giving myself any excuses, but there's two elements to the handover that made it for me difficult. The first element was that you're not given a handover sheet as you will be looking at it in front of you if you're sitting in a handover for the ward, and you have the whole sheet there, so you're able to sort of have a good overview. Again, you have to scroll back and forward and up and down. So my brain is a bit so I kept forgetting things as I would go up and down. So my advice is to get a piece of paper. If the software is still the same, I don't know, maybe they've changed it. Maybe there's a way to download it to the computer that it looks better. People who are more tech savvy than me, but get a piece of paper and just write number one. It was this, the age was this, I would do this, the outcome was this. I'd ask so-and-so to do it. I'd ask. Then the other thing is, I think, don't get too hooked up on, because you're doing a subspecialty and whatever it is, that handover is going to be related to that. It's a basic general pediatrics ward handover. Okay, the bread and butter that all of us as pediatricians do. Don't get too caught up in, like, we were reading like breach reports, managing the board. We had screenshots of the A&E board. Like, we're really hooked up on that it was going to be a board round or a breach report or a performance report from A&E. Again, people in NICU, people who do other specialties will be hooked up that it's going to be, it's your general pediatrics ward with your wheezers, your gastroenteritis, your sickler. It's the bread and butter. So don't get like too excited about it. Just focus on the basics. And that's my advice. So I'm sharing my feedback from that station, which was the only station where I had remediation on, to see if this will be helpful for you. So it was the scenario where we were short-staffed. We had like, and it's always going to be a scenario where you're short-staffed. And we had like a GP trainee, I think an F2 and a reg on the ward, and I was the consultant. So then I straight away said, oh, that's so-and-so to do this, so-and-so would need to go on this, because I was trying to prioritize who's the sickest one on the ward, which we all would do. So the feedback was, before you delegated tasks to juniors, it could have been better to consider their experience and capacity. So obviously, so it seems like it's stating the obvious, but the examiner can't read your mind. So obviously, when you're at work, you will know who is capable of what. Maybe not always, if you're in a situation where you have new colleagues or you come in for a locum shift or whatever, but you will always check. You'll always say, is that okay? Are you happy to do that? What else are you doing? Are you free now? So what have you got to do? You will always ask that. You're not going to give somebody workload which is out of their capacity or above their skill mix or experience. This is sort of common sense. However, in the exam, you really need to mention everything. You can't assume things, okay? There was a child on the ward with bloody diarrhea. Me, in my A&E brain, I was like, oh, gastroenteritis, obs are fine. Looks like they're getting better. They can go home, because I want to get everybody home. The discussion was, think about potential IBD, interception, possible. So discuss the differentials. Yes, on paper, it looks to you like gastroenteritis. The child looks like they're getting better. They can possibly go home, but mention. Obviously, we would need to rule out IBD. We would need to make sure this is not. So you need to, this is, it looks very obvious. It looks like, but you have to say it, okay? Though in the scenario, though they gave me the handover and there was a child in A&E with a fracture. So I said that I would, I'd ask A&E, because we had a few sick ones on the ward. I asked my A&E colleagues to get the ball rolling with the child with the fracture until we're able to assess. I think fracture, and we would be, our input as like the general pediatrics team would be the safeguarding. So then the feedback, as you can see there, you may need to consider immediate pain, because I said, oh, get the ball rolling, get the x-rays done and that, and may need to consider immediate pain relief. And obviously, in my mind, like that's a given. And you would not see a child in pain with a fracture and not prescribe pain relief, but you have to say it in the exam. Just I cannot emphasize more, and you have to say everything. And then I think could have been better if you had considered a potential for teaching opportunity. In my sort of, again, A&E mind, I just want to get this done, get everyone out. But I didn't consider any opportunity for teaching on this ward round. So again, you can go back to the very first template. So even the handover, obviously, is an opportunity for teaching, whether that be in handover or during the ward round, or to discuss any of the potentially interesting cases. So you have a GP trainee and you have an F2. So any of these cases are learning for these colleagues. So you have to, so this was the feedback from that station. I was asked to remediate. The remediation is nothing difficult. Some people have been given like suggestions to do like courses. My suggestion was to, I think read the guidelines for hyperkalemia, which I did in an evening. It's very like, there's nothing major that you will have to do. And then ethics, often there will be scenarios about confidentiality, consent, capacity, read things like Gillick competency. These are things you need to refresh yourself with. The Gillick competence, Fraser competence, consent, parental responsibility, confidentiality, and then child death, particularly those of you who are doing neonates, because there's a lot of redirection of care and things like that. So I have a really good PowerPoint presentation about all the aspects of child death and what you need to do in an unexpected child death or unexpected, the processes you need to do. So I can share that with you. It's because thankfully it's not something we have to deal with every day. So just be familiar with the processes and who you need to call and what needs to happen after an unexpected child death. Because you may get a scenario where you're the consultant, you're called in, they're doing CPR, and so you have to sort of call it, and then what's the process from there? And then things like withholding care, palliative care, redirection of care, these are guidelines you need to sort of read through. And then complaints, I think you need to be familiar with the complaint process. I did, on one of the groups, I did a voice message about that. I can share it if need be, but it's just, and if as a senior trainee, if you get an opportunity to actually respond to a complaint, then it will be very easy for you to respond to this question. It's often a parent wasn't happy with the way they were spoken to, or they read something on the discharge letter, or they weren't happy with the delay in A&E or whatever. So in every trust, a complaint comes through to the complaints team, and there'll be a sort of a written response from the complaints team within 48 hours of receiving that complaint, acknowledgement that this complaint has been received, and then it will be directed to somebody to look at it, usually the matrons, and then they will send it on to the consultants. And then also, again, remember you're a consultant day one. So always say things like, this possibly could be the first time I'm dealing with a formal complaint, so I would need to seek support from people who've done it before, like the matrons, my consultant colleagues. And then it will be things like gathering statements from people who are involved, making a timeline, looking at, does this complaint warrant discussion at trust governance, local governance, like the unit governance? Was there any harm came to the patient, or is it just something that the parents weren't happy about in terms of something written on a letter, or for example, I had one recently where someone was given an incorrect discharge letter. Again, you have to address that, like whether it can be dealt with over the phone, whether the parents would be happy with a phone call, whether they would like a sit-down meeting to resolve this, whether they need it in writing. I remember the lady, I called her, and the lady said, I accept the apology, but I would like it in writing. So you have to sort of write a template and explain and apologize and that. And then whether actual harm has happened, and then you do a timeline, and then it would go and be discussed at sort of trust governance level, and then whether the family want to take it further, as in to kind of gain sort of financial reward and whatever. That's sort of a bigger level. Be familiar with PSERF. PSERF has come in now instead of the incidence or the SIs previously. So PSERF is about sort of learning and quality improvement around incidents that have happened. So just be familiar that that has changed from sort of SI. Now it's changed. So just read on your local trust guidance. Just a few things to read up on and be familiar with in these kind of situations. Again, if you think about the template, it's about the patient safety. Did harm come to the patient? Communication, discussion with the parents, discussion with the colleagues who were involved. How are they feeling? So again, the same template applies in every scenario. Conflict and logistics, again, it could be a situation where a colleague is being obstructive, conflict between two colleagues, disagreement between two colleagues, things like, for the scenario I had is that you're the consultant, your ST2 is in the waiting room with her baby who's unwell. You go and like say hello to her, and then the nurse in charge is very upset, thinks that this ST2 is sort of skipping the queue or using their sort of authority and skipping the queue. And also you discover that this ST2 person is on the night shift in 4 hours time, and she has a sick baby and they're in the waiting room in A&E. So this is thinking about, so there's a bit of conflict there with the nurse not being happy that I went to see her or sort of inquire about her baby. And there's a bit of logistics because you have your ST2 who's covering the night shift, who has a sick baby who's sitting in my waiting room at 4 o'clock. So what do I do? So you have to think about the safety of the night shift. You have to think about the discussion with the nurse in charge, and you have to think about that colleague. Do they need time off? Do they need carers leave? So these are logistical things you need to think about. And then raising sort of concerns if there's a recurring issue or recurring obstruction or conflict from a particular colleague or issues, then how to escalate them. Escalate initially would be to their supervisor. If that, you may need to escalate to the clinical lead. You may need to escalate to, if they're a trainee, to the TBD. So these are knowing how to escalate, and then thinking about improving the service in general. There was a lot of hype about there being a business case in the START assessment. In my assessment, there wasn't, but it's good to be familiar with how to write up a business case. So we can probably do that in one of the upcoming sessions. And then learning and development. For me, what I found most helpful is studying in group. What we did was we had a WhatsApp group, and then we had a recurring link, Zoom link, and whoever was free in the evening in the couple of weeks before the assessment, we just jump on the call and do some practice some questions. There is a question bank that's going around, or just, you know, discuss relevant documents or papers or whatever. And we only did that for like 2 weeks before the assessment. We were on the group that it was scheduled and then cancelled because of strike. It was pushed forward another 2 months. So when it was pushed forward, we stopped doing anything, and then we came back again a week or two before, and we were doing a bit of practice. And it doesn't have to be really like rigorous. It's just whenever you're free, if you're around in the evening, just hop on. I think that I found that the most useful, just talking through with colleagues. Yeah, sorry, I think that I went over time. Any questions?
Thank you so much, Nadia, for your amazing tips and practical approach you shared with us today. It is really such a well-structured and helpful session, and we learn a lot from this. We appreciate your time and effort and dictated being here with us. And now you are welcome for any question. Please, you can unmute yourself. We have a question in the chat. It is about the context. What is the context for handover, handing over to the evening team, or discussing before ward round?
It's like a morning handover usually on the ward.
All right.
Hi.
Yes.
So I ask something. Just a very a quick clarification about the teaching session, which hopefully is going to be not so particularly difficult for any of us. But are we approaching this as a proper, so is a scenario where we actually ask the student or medical student, tell me what you know. So we gauge their knowledge, we ask for who they are, and we wait for the answer? Or am I just saying, I'm going to gauge their knowledge, I'm going to ask who they are? I mean, is it a proper scenario where they interact with us and we wait for them to answer?
Yeah, you will interact. You will have 3 students on the call,
Okay.
and you will interact with them as if you were teaching them in just that's why try keep it very basic, so you can it doesn't become like it's you don't get interrupted in the middle of it because you have to move. So keep it very basic so you can say everything you need to say, but keep it interactive as if you were actually teaching them.
Okay, thank you.
And Emma on the chat, she just put it her email and she wants you to share the presentation with her, if that's all right. Also, Iman asked if you can share the slide in the Start WhatsApp group. We can do that, Iman,
Sure,
yeah.
sure.
And there is a question about what does PSIRF, but it is already answered. Thank you, Ibrahim. And I got some question from your booking, if no one got any question. There is a question about there is any difference between start for spin or grid?
No.
All right. And there is the question about how long we need to prepare for the start.
You really don't need to. I know it sounds, because we've done it and it's behind us. I know it sounds, but it doesn't need much preparation. The easiest thing is, as I said, to get with a group of people and just go through a couple of questions. If there's anything you feel you need to refresh yourself on, like the child death, the redirection of care, the consent, the capacity, these things, just quick refresh. Don't go in depth and get yourself into them. It really doesn't. Everything you will discuss in the start is what you do every day. The purpose of preparing is just to get yourself into that mode of answering it easily, so because of the time restraint of the assessment. But there's nothing that you guys don't already know.
I hope it will this answer will be enough. And there is a question about how we will pass the start. As you mentioned, it is assessment, it is not a test, but there is a question about how we will pass it.
So it's not pass or fail, it's an assessment, and you will be given some remediation to do. It varies from one person to another what they want you to do. So sometimes, for me, example, they ask me to, it can be quite random. And then the assessors will always put something very generic, like, remember to refer to RCPCH safeguarding guidance. Like, okay, fine, thank you. You don't need to actually do it. Like, unless the station, you have further your score is further development required, then you will go back and look at what they've asked you to do. Some people get asked to do prescribing courses. Some people get asked to do safeguarding course or something. There's a difference between if you're asked to actually do something or suggestions. So some suggestions you can just look at, all right, thank you. But there's things that actually need to be done when you before you CCT. So that's the assessment is done. You will need to have remediated for CCT on the points that they've asked you to remediate on. And most of it you can do in like an evening. I'll show you, let me share another document. Just give me a sec. So this, can you see that document?
Yes.
Yeah, so I can share with you the template. This is a template which I use to do my, because when you finish, you have to, on your Kaizen, you have to put your start, you have to respond to the start feedback and put everything in when you submit your thing for final ARCP. So I use this document, which somebody very helpfully shared on the start. Let me just go down and show it to you all. So it just, see how at the top it shows you all the elements of the of the marking of each station. And then I write the comments I was given, and then what I had to do, the reflection here at the bottom. Okay. So I'll share with you this. This just makes it easy when you finish the start and you get the start feedback. You just put it into here and you can upload that to Kaizen, and then that will show you have remediated. So look, for here, you didn't mention hypokalemia and potential rising CO2. So then down here, I said, I prioritize. So this is my response to this is my reflection, if you read it. So I prioritized, delegated appropriately, I agreed, I managed this appropriately, not sure of the situation warranted the blood transfusion. So these are some of the responses. And I said that I've read the hypokalemia guidance. I have read the hypokalemia previously and updated with asthma BTS guidelines. I commonly refer to RCPCH companion. So, and then the action I've taken, I have refreshed myself with the BTS guidelines and hypokalemia guidelines. So if you've highlighted the action, then that's it. You've remediated your start. So the rest of my stations didn't need any actions, so I just wrote them here. But you highlight your reflection and your actions. So I can share that document. That just makes it much easier when you're in, because for us it was very tight between the time of the start and the CCT time. It was like 2 weeks. So we had to get everything ready. If you have ample time, if you're still SC6 or 7, it's fine. But if you're really time is pressing to CCT, it's useful to use this template.
Thank you so much, Nadia. And there is also Nairoz ask a question in the chat. Do you think if you are prompted to answer some question, then you are less likely to get a higher mark?
No.
And a lot of trainees ask about this presentation. Just to highlight, this presentation is recorded and it will be in the platform of the British Sudanese Association of Pediatric and Child Health at the YouTube, and also we will share it with the groups.
Yeah, I've also did the same presentation for London School of Pediatrics. So if you go on their YouTube channel, it's there as well, if you want to access it before it's uploaded here.
A lot of thank you, very informative. I was just to see if anyone got a question, feel free to unmute yourself and ask.
Sorry, can I ask you something, Nadia? You mentioned that you were very tight for time, like you did this possibilities assessment quite close to your CCT date, is actually exactly the same situation I am in.
Mm-hmm.
But so if you, are you telling me that if you do the start and actually you do your remediation, you would still be allowed to CCT, you know, in the following few months, or they will ask you, no, you have to do another year because we do the start at least 1 year before? No.
Not at all. I got my start feedback,
Yeah.
and I submitted within the same week. I submitted for CCT because for us we were in a fortunate situation where it was the strike, so it was cancelled, and then we did it in December, and I was CCTing in February. The Christmas holiday came in the middle, so we got the start feedback by the end of January.
Oh.
I was supposed to submit at the end of January. They even the school kindly extended our deadline for ARCP because of this. And then, so we were in a very tight situation. It was very nerve-wracking, but we did there was 4 of us, but we did manage to CCT on time.
Thank you. Thanks.
There is another question.
I have a small question. Yeah. Would you recommend any course for conflict resolution?
Not that I know of. So I'd have to have a look. I haven't taken any course myself. Sorry, I don't. Yeah.
Yeah. All right. I find it like tricky. That's why. Thank you.
If no one got any questions, there is no other question in the chat. There is the link of the feedback in the chat. Please share this feedback, and we want to know how to improve the future session. And also, I would like to thank you, Nadia, for this nice presentation and for your coming and joining us today. And thank you to all that who came today and participate and join us in this one. The next start series will be on 14th of December, and we will shortly announce it Thank you so much.
Thank you very much for having me. Thank you. Good luck, everyone.
Thank you.